guys, we're back this month with part 2 of the Choosing Wisely discussion. I hope you all got something useful out of the discussion in part 1 last month, and today we're going to wrap it up with the last 3 of ACEP's recommendations. These are a little bit simpler and don't require quite as much deep thought as the last 2, but there's still some good stuff here, so let's get to it. Today's discussion is just going to continue what we started last month and finish up our discussion of ACEP's recommendations, and also consider the role of the emergency physician in regards to medical stewardship and how this relates to individual patient care. Since it's July and it's still wicked hot out, I thought we'd continue last month's theme and cool off with some more of Calvin's snowmen. Alright, recommendation number 8. Avoid lumbar spine imaging in the emergency department for adults with atraumatic back pain unless the patient has severe or progressive neurologic deficits or is suspected of having a serious underlying condition, such as vertebral infection or cancer with bony metastasis. Acute non-traumatic back pain is an incredibly common presenting complaint to the ED and to primary care in general. In 2008, there were over 7 million ED visits for back pain, and it's estimated that about 70% of adults will experience back pain that affects their ability to perform daily activity at least once during their lifetime. In the US alone, it's estimated that almost 150 million workdays are lost annually because of back pain, with an estimated cost of over $2 billion. So back pain is common and costs us a lot, and not just in healthcare spending, which is why low back pain has been studied 6 ways from Sunday in order to get a better understanding of the natural history of back pain, who to test, and how to treat it. Pretty much every guideline out there will recommend avoiding imaging in the acute setting, since the majority of back pain isn't caused by a structural problem that can be identified on routine imaging studies. The emergency medicine community is far from alone on this one. In fact, 4 other major societies have also made recommendations that are essentially identical and recommend that imaging should not be performed in otherwise healthy adults with back pain unless they've been screened and certain red flags are noted on their exams. Speaking of, let's talk red flags a little bit. Red flags are pretty much exactly what they sound like, and I think most of us are pretty familiar with them, but it never hurts to fly through the major players. Think of these as their historical tidbits that can clue you in when there's something more than just mechanical back pain going on. Typically, some form of testing is going to be indicated for these red flags, and most often, that's going to involve some kind of imaging test. This is a brief list of the red flags in patients presenting with back pain to the ED that may indicate that early imaging of the spine is required, including neurological deficits such as weakness or numbness, any bowel or bladder dysfunction, fever, history of cancer, history of IV drug use, immunosuppression, steroid use, and extremes of age. The literature cites age over 50 as the beginning of a higher risk category, but for the most part, I admittedly don't routinely image at any age, although I do typically image more liberally in the folks over age 50, particularly once they start getting over age 65 or 70. Because these patients are older, they're sicker, they have more comorbidities, and they're much more likely to have something bad wrong with them. Most of the red flags can help you narrow down your differential diagnosis as well. Progressive neurological symptoms can be seen with most of these categories and is probably the least specific. In patients that have either a current or a prior history of a malignancy, consider imaging with CT if you're suspicious of bony metastatic disease. In particular, the lead kettle or PBKTL cancers, including prostate, breast, kidney, thyroid, and lung, really like to spread to the bones of the thoracic and low back because of the drainage of blood through the anatomic venous plexus surrounding the area. Lymphomas can also spread to the bones, but they tend to like to set up shop in the epidural space a little bit more commonly. This is also a diagnosis to consider if your patient had a lot of unexplained weight loss, is elderly, or has been having ongoing pain without improvement for several weeks. Patients that present with fever, a history of IV drug use, or those who have had a recent epidural procedure are at higher risk of infections. While epidural abscess is the one we tend to think about in these folks, immunosuppressed patients or those with underlying illness such as recent endocarditis or other recent infections can also develop other infections like discitis or osteomyelitis and so on. In addition to imaging these patients, the addition of laboratory studies including cultures, sed rate, and CRP may also be useful. Cauda-Equina syndrome is another one I think we're all pretty familiar with. The bowel and bladder dysfunction is classically incontinence, but urinary retention is actually more specific, and the incontinence tends to be due more to overflow. Checking a post-void residual can be helpful, along with imaging in these patients. And of course, in patients with trauma, think about fractures. That being said, in the elderly and osteoporotic patient, it may take minimal or even no trauma to sustain a compression fracture. If a patient has been on chronic steroids, such as a COPD patient, they may also be at higher risk for fracture despite minimal traumatic mechanism as well. So why not just image people with back pain early? Would it actually help any of these people get better any faster? This paper looked at that very question, and it's a meta-analysis of 6 trials including just over 1,800 patients, looking at patients that got immediate imaging, including either plain film, MRI, or CT scan, versus those that didn't and who were managed conservatively. They looked at the patient's pain or function as the primary outcomes, but also included assessments of quality of life, mental health, overall patient-reported improvement based on various scales, and patient satisfaction in the care that they received. Regardless of whether follow-up occurred at 3 months or at 6 to 12 months, there were no significant differences between the groups for any of the different outcome measures. It didn't matter what type of imaging was done, nor did the duration of pain. I'll grant you that in the grand scheme of people with back pain, this really isn't a very big trial. But even if you had a huge study population and were able to show a statistical advantage, a difference so small that you need to enroll thousands and thousands of patients to find it is unlikely to be clinically significant. Another reason not to image early is that an abnormal imaging study does not necessarily correlate with pain or with disease. In this paper, published in the New England Journal in 1994, they took 98 asymptomatic people and did MRI of the spine on all of them. For good measure, they also mixed in 27 patients that had ongoing back pain and had 2 independent neuroradiologists read all of the films. When they looked at them, 36% of the totally asymptomatic patients had normal discs at all levels, and 52% of them had disc bulging at 1 or more levels, 38% of them having multi-level disease. 27% of them had disc protrusion at 1 or more levels, and 8% of them had facet arthropathy, and this is of the asymptomatic patients. In fact, the conclusion of the paper was, given the high prevalence of these findings and of back pain, discovery by MRI of disc bulges or protrusions in people with back pain may be coincidental. So the bottom line here is that the presence of structural disease does not necessarily correlate to the patient's symptoms, so imaging looking for this stuff in the ED probably has very little utility unless you're looking for some other kind of badness based on your H&P. So to wrap up our discussion about ACEP's 7th recommendation, in adults with non-traumatic low back pain, you don't need to do any routine imaging. Do a good H&P, look for the red flags, and limit your imaging and testing to these folks. And of course, consider diagnoses outside the back as well, like that AAA, pancreatitis, urinary tract infection, and so on. But for that normal healthy person with just mechanical back pain, you don't need to image them in the ED. Okay, on to recommendation number 9. Avoid prescribing antibiotics in the emergency department for uncomplicated sinusitis. Sinusitis is a common reason for patients to visit the emergency department, but most patients with acute sinusitis do not require an antibiotic treatment because 98% of acute sinusitis cases are caused by viral infections and will resolve in about 10 to 14 days without treatment. Because the nasal mucosa lining the nasal passages is contiguous with that of the paranasal sinuses, any inflammation of the sinuses is almost always accompanied by inflammation of the nasal cavity, hence the term rhinosinusitis. A viral etiology associated with an upper respiratory infection or the common cold is the most frequent cause of acute rhinosinusitis. This is an incredibly common condition affecting a huge number of people annually. In adults, the incidence is estimated to be 2 to 3 episodes per year, and prospective longitudinal studies performed in young children, particularly the toddler crowd ranging in 6 to 35 months of age, revealed that a viral upper respiratory infection occurs with an incidence of 6 episodes per patient year. So yes, if it seems like the little kiddos are always sick, it's because they are, and that's normal. Secondary bacterial infection of the paranasal sinuses following an antecedent viral upper respiratory infection is also relatively uncommon, estimated to involve about 0.5 to 2% of adult cases and up to 5% in children. Other causes, such as fungal infections, are rare, and non-infectious etiologies include allergic and environmental irritants. We see a ginormous number of patients annually in the ED that basically have a cold, and some of them need some hand-holding and reassurance, and some might benefit from a prescription for some coping skills. Despite its overwhelming viral predominance, rhinosinusitis is the 5th most common indication for antibiotic prescriptions in the U.S. We do a little bit better in the ED than they do in primary care. A recent national survey of antibiotic prescriptions for upper respiratory infections in the outpatient primary care setting showed that antibiotics were prescribed for 81% of adults with acute rhinosinusitis. And that's just bonkers. We came in with rates of treating viral upper respiratory infections between 25 to 40% of the time, which means we're doing a little better than they are, but we still have a lot of room for improvement in the ED as well. So the question on everybody's minds right now is, why should we care? Well, antibiotic resistance is bad. There are some superbugs out there, folks. There are some strains of things like VRE and MRSA that are basically resistant to everything. Since 1998, the FDA has only approved 11 new antibiotics, and most of these were not novel drugs, meaning that they were part of an existing drug class like the tetracyclines or the cephalosporins. Meanwhile, drug-resistant bacteria have spread in both community and healthcare settings, affecting approximately 2 million Americans in 2011, and of those, about 23,000 died as a result of their drug-resistant infection. Likewise, C. diff is bad too. It's becoming more common, and it's difficult to treat, with relapse rates as high as 20 to 25%. And treatment relapse involves things like fecal transplant, which sounds absolutely nasty. In severe cases, it can also result in things like toxic megacolon, sepsis, total colectomies, and this occurs in 3 to 4% of patients that get C. diff, with mortality rates in the 35 to 50% range for those patients. So C. diff is no joke. The CDC estimates that we can reduce the incidence of C. diff by about 25% if we could just reduce unnecessary bug juice by 30%. We overtreat sinusitis way more than 30% of the time, so it's not a bad place to shave some of this excess. In 2012, the IDSA made new guidelines for sinusitis, and the primary goal of the guideline was to improve the appropriate use of first-line antibiotics for patients with the presumptive diagnosis of acute bacterial rhinosinusitis, while reducing excessive or inappropriate use of bug juice in patients with viral or self-limited infection that is going to resolve spontaneously, thus deterring the emergence of antibiotic resistance among respiratory pathogens. And the guideline was developed with us in mind, docs practicing in the community and emergency department settings. The first recommendation from the IDSA 2012 guideline tries to answer the question of, who do we treat? They identified 3 clinical presentations that are more likely to indicate a bacterial pathogen or a more serious illness that may benefit from the use of antibiotics. The first group they recommend treating are the patients that have had persistent symptoms or signs compatible with sinusitis lasting for 10 or more days without any evidence of clinical improvement. These aren't the patients with ongoing lingering symptoms 10 days into their typical viral illness. It's the patient that have ongoing, lasting, persistent, not getting any better symptoms. The second group are the group that have severe symptoms such as high fever greater than 39 degrees C, purulent nasal discharge or facial pain that's persistent and lasting for more than 3 to 4 consecutive days at the beginning of their illness. Group 3 are what I call the double sick folks. They're the ones that had worsening signs or symptoms of fever, headache, increase in nasal discharge after they had a typical viral upper respiratory infection that lasted a week or so and was initially improving, and then they got sicker again. All right, now the obvious follow-up question is, now that we know who to treat, what do we treat with when we do treat? For first-line treatment, they're recommending amoxiclav rather than amoxicillin alone for both children and adults. They're also recommending a beta-lactam over a respiratory fluoroquinolone and over a macrolide or Bactrim due to high resistance rates among strep new and H. flu. Doxycycline or respiratory fluoroquinolone is recommended for patients that have a penicillin allergy, and for children with an allergy to penicillin, they're actually recommending either Levaquin or a combination approach using clindamycin plus a third-generation cephalosporin. The last thing I think we should really take away from the guidelines is that there is still some weird stuff out there that can present as recurrent sinusitis that just keeps getting worse, so it's important to know when you're beaten. If the patient isn't getting better despite doing all the normal things, it's time to have them go see the specialist. Things like Wegener's granulomatosis, mucormycosis, and so on are out there, and they're rare, and it's probably not something we're going to be able to diagnose in the ED. Also, while uncomplicated sinusitis rarely causes problems, there are occasionally those rare cases of intracranial extension, and those patients will show up looking sicker, with meningitis, cavernous sinus thromboses, orbital cellulitis, facial osteomyelitis, and other badness. So if the patient looks toxic, all of this stuff goes out the window and those patients get worked up. The IDSA published a treatment algorithm applicable to primary care and has some utility for the specialists as well. I like it, but I sort of trimmed it down just a little bit to keep it simple for the approach in the ED. So basically, if you've evaluated the patient and they meet one of the 3 criteria put forth by the IDSA and you've decided that the patient merits antibiotic treatment, start with a beta-lactam. If the patient fails that, you can try a fluoroquinolone or doxycycline, and if they fail that, then refer them to a specialist. And if they look sick, work them up for the weird stuff. Just like the last recommendation we talked about, the emergency medicine community isn't alone on this one either. The American Academy of Family Physicians and the American Academy of Allergy, Asthma, and Immunology both weighed in on this topic as well, and both agree that we need to stop treating all these uncomplicated cases of sinusitis with antibiotics. Here's a little bonus pearl on sinusitis. If you have a patient with what sounds like uncomplicated rhinosinusitis, you don't need to image that patient in the ED. Save the imaging for the folks that have failed treatment or look like they may be having a complication of their sinusitis, those who are immunocompromised, or the ones that look sick and you think there's something else going on that they need to be worked up for. So the bottom line for ACEP's 9th recommendation is that most patients with rhinosinusitis have a virus. You don't need to treat those patients with antibiotics unless they've had no improvement for greater than 10 days. And no improvement doesn't just mean that they're not all the way better, it means absolutely no improvement. Or, if they look sick, fever greater than 39 degrees, headache, purulent rhinorrhea for greater than 3 to 4 days, or they have worsening symptoms following a typical URI, or the double sick patient. Alright guys, hang in there because we're almost done. ACEP's last recommendation is that we can probably avoid ordering CTs of the abdomen and pelvis in young, otherwise healthy emergency department patients with known histories of kidney stones presenting with symptoms of uncomplicated recurrent kidney stones. As we all know, Kidney stones are a super common presenting complaint to the ED. The lifetime prevalence of kidney stones is about 12% in males and about 7% in females, but this number has been steadily rising over the last 20 to 30 years. Approximately 2 million patients present for medical care annually because of kidney stones. In fact, we're up 40% in the last 20 years. The reasons for this aren't entirely clear, as there also is a lot of geographic and racial variability in who gets kidney stones as well. But on average, the likelihood that a white U.S. male will develop kidney stone disease by age 70 is about 1 in 8. And it's nice to let your patients know that they're really likely to get a stone again in the future, with better than a 50% chance of recurrent stones over the course of the next 10 years following their first presentation. Since recurrent stones are so common, this is basically low-hanging fruit for us in the U.S. and is a great place for us to look at reducing unnecessary testing. How many times have you walked in to see a patient sitting on the gurney, pale, sweaty, clutching their sides, saying, "Doc, I've got another kidney stone"? Passing a kidney stone is an experience that most people aren't really going to forget, since it can be tremendously unpleasant. Most of these patients already know what they have, and they don't need us to do a CT scan to tell them what it is. The reasons to image a patient with kidney stones are basically twofold. First of all, to confirm the diagnosis. Second, to see how big and where the stone is. Size does matter to some degree, in that larger stones are less likely to pass spontaneously and to take longer to pass when they do. However, it probably doesn't really matter all that much on the patient's initial presentation how big or where the stone is, since the majority of stones are small, and as long as the patient's symptoms can be easily controlled, a trial of expectant management is typically the norm anyway, regardless of stone size. When we consider the indications for emergent intervention to remove a kidney stone, you'll notice that size isn't on the list and isn't a reason to take the stone out independently of other factors. In our prior discussion of CT for pulmonary embolism last month, we discussed the huge increase in CT utilization for that diagnosis. Because CT is so easily available in the ED, essentially the same thing has happened with kidney stones, and again, without any increase in the frequency of diagnosis or improvement in patient outcomes. This study looked at data from the National Hospital Ambulatory Medical Care Survey from 2000 to 2008, including data from hospitals in all 50 states. In 2000, CT was obtained in just under 20% of cases, whereas in 2008, CT was obtained in over 45% of cases. The use of X-ray decreased between 2000 and 2008, and the use of ultrasound really didn't change significantly over this time frame. Despite more than a doubling in CT utilization, the number of patients diagnosed with kidney stones didn't significantly change from 2000 to 2008. Other downsides to this increasing use of CT include the exposure to ionizing radiation with the attendant long-term cancer risk. And of course, CT is also associated with a high rate of incidental findings, such as asymptomatic cysts and nodules, the majority of which turn into great big nothing balls that can lead to inappropriate follow-up, testing, or other procedures. Unfortunately for them, patients with recurrent stones are at particular risk of getting turned into glowworms with repeated CTs. This particular paper was done at a single institution over the course of 6 years and included 4,562 patients who got a CT scan for suspected kidney stone. The majority of the patients only got one exam, but there was a subset of patients that got lots of repeat imaging for recurrent stones during the trial period. The average radiation dose for a single study was 6.5 millisieverts for a single detector CT and 8.5 millisieverts for a multi-detector CT. There were 176 patients, representing 4% of the total population, that had 3 or more CT examinations, and their estimated total doses of radiation ranged anywhere from 19.5 to a truly ridiculous 153 millisieverts. And all of the patients that had multiple examinations had a known history of kidney stones. The major limitation of the study was that they really didn't clearly report on whether folks that got truly ridiculous amounts of radiation had complicated illness that actually warranted repeat CT scans. but the implication was that these patients all had generally uncomplicated illness. Let's look at that subset of 176 patients that got multiple CTs. While the majority of these patients only got 3, maybe 4 CT scans over the 6-year trial period, I would still argue that that's kind of a lot of radiation. And if they got that many CTs over 6 years, how much radiation are they going to get over their entire lifetime? What's really crazy is there were a few patients that got 9, 10, even 15 or more studies over that time period. One patient actually got 18 CT scans just for flank pain in the 6-year trial period. That's just bananas and is a huge amount of radiation exposure. When we look at the patients in the paper to see how much radiation exposure actually occurred, the patients who underwent 3 or more examinations got an effective dose ranging from 19.5 to 153.7 millisieverts. All the patients with multiple examinations had a known history of kidney stones, which means they'd probably undergone some kind of imaging prior to the study as well, so some of these folks may actually glow in the dark by now. It's been estimated that the risk of fatal cancer is about 0.05% or 1 in 2,000 for a 10 millisievert dose of ionizing radiation. This estimate was established by the International Commission on Radiological Protection. Those patients who undergo more CT examinations would thus assume a greater risk after each subsequent scan, with an estimated risk of fatal cancer as high in 130 for the patient who underwent CT examinations. What's worse, these estimations only account for CT examinations performed at the study institution during that 6-year period. Who knows how many other studies or procedures this poor patient got somewhere else since or prior to the study? Fortunately, we've got options. How about using ultrasound instead of CT as the initial diagnostic of choice in these patients? The European Association of Urology recommends that ultrasound should be used as the primary diagnostic imaging tool in patients with flank pain. The Europeans do tend to be a bit ahead of us in the United States when it comes to adopting radiation-sparing practices. Even in first-time presenters, they're recommending using ultrasound as the diagnostic test of choice. However, the American Urological Association is still recommending CT as the initial diagnostic test of choice in patients with a first-time presentation. They acknowledge the risk of repeated radiation exposure in patients with recurrent stones, and thus their guideline also states that renal ultrasonography and KUB are viable options for a known stone former who has previously had radio-opaque stones. The evidence for using CT as the first-line diagnostic test of choice isn't robust, and there's no evidence that using CT over ultrasound in first-time presenters results in improved patient outcomes. This paper was published last year in the New England Journal and looked at ultrasound versus CT for suspected kidney stones. They randomized a total of 2,759 patients, 908 to point-of-care ultrasound, 893 to a formal ultrasound, and 958 to CT scanning. They only included patients that the treating doc really thought had a kidney stone. The patients that were coming in with sort of the soft appy rule out, or the patient that was thought to be more likely to have something else going on, was excluded. The incidence of high-risk diagnoses with complications in the first 30 days was low, at 0.4% overall, and didn't vary according to the imaging method. In the point-of-care ultrasound group, there were 6 complications in the first 30 days, 3 of which were correctly diagnosed stones that went on to develop urinary tract infection or urosepsis. A 4th went on to develop pyelo at 30 days, and so it's hard for me to call any of these a miss. One patient was given the correct diagnosis of diverticulitis and subsequently returned with a perf, and there was one patient that had a small bowel obstruction that was missed, and this went on to develop GI ischemia and a bowel resection. In the formal ultrasound group, complications included a correctly diagnosed ovarian cyst that went on to develop torsion, and a missed renal abscess, as well as a correctly diagnosed stone that also developed a UTI. In the CT group, there were also 2 correctly diagnosed stones that went on to develop urosepsis. As one might expect, the mean 6-month cumulative radiation exposure was significantly lower in both of the ultrasound groups than in the CT group. By day 7, the average pain score was 2 in each group, and there were no differences among the groups in return ED visits, hospitalizations, or in overall diagnostic accuracy. What we need is a rational approach to these patients. So here's the basic decision tree that can help you decide if and how to image these patients. Say you've got a patient with a known history of prior kidney stones. All of their prior stones passed spontaneously and without any complications. The patient describes the pain as being basically the same as his prior stones. So what does CT really add to their initial evaluation? If it sounds like a stone, there's really no downside to a trial of expectant management as long as the patient's symptoms are adequately controlled. If you do feel strongly that you still need imaging to confirm the diagnosis, go for ultrasound on their first visit. The majority of these stones will pass without complications, so knowing where it is and how big it is really doesn't matter. Even if you did get a CT and the patient had a big stone, as long as their symptoms are controlled, the urologist is still going to recommend a period of observation, as 1 in 5 stones that are 8 millimeters or greater are still actually going to pass on their own. And if they very appropriately come back, if they didn't improve after 2 to 3 days, image the patient then, since they failed conservative management. You'd probably image them on the second visit again anyway, so you'd spared them at least one CAT scan by doing so. Now here are the caveats. This thought process doesn't apply in some groups of patients that are high risk, such as patients with a unilateral kidney, patients with a concurrent UTI or fever, or if the patient happens to be one of the unlucky ones that has needed multiple prior stents or procedures because of failed stone passage. And number 2, this whole discussion is in regards to patients with recurrent stones. It's completely reasonable to consider some form of imaging for patients with flank pain that are first presenters with no prior history of stones. Moreover, if you think that the diagnosis is in question and you clinically suspect that something else is causing the patient's flank pain, then obtaining imaging would be very appropriate. The way we image patients may be changing in the next few years. With advances in CT technology, some super low-dose protocols are being developed for clinical use that could see radiation exposures decrease tenfold. That changes the equation dramatically, although choosing the approach that doesn't expose the patient with recurrent stones to radiation at all may still be the best approach. Ultrasound technology has also been improving, and point-of-care ultrasound is becoming more and more prevalent as well, with emergency physicians performing more of these scans at the patient's bedside, saving both time and radiation exposure. So let's bring this one home with the bottom line for ACEP's final recommendation. The majority of patients presenting with recurrent kidney stones don't need imaging at all. In fact, most people with recurrent stones know exactly what their stones feel like, and they already know that they have a kidney stone when they're coming to the ED. Unless they have signs or symptoms of a complicated stone, you probably don't need to image that patient at all. Look at it this way. If you get the CT and the patient has a stone, what are you going to do about it? You're going to control their pain and have them follow up in 3 to 5 days. If you don't get a CT, you're going to control their pain and have them follow up in 3 to 5 days, so it's not going to change anything you do after that initial visit. However, if you do feel that imaging is necessary, consider starting with an ultrasound in order to minimize the patient's exposure to radiation. So who does need a CT? Well, now we're kind of wandering off into the realms of my own opinions, but if the patient has already failed a trial of conservative management or has evidence of complications such as renal failure, fever, associated UTI, you may want to consider imaging these folks. Also, if the patient has a solitary kidney, consider an ultrasound or a CT, particularly if there is evidence of a decline in renal function. This is a little less scientific as well, but if the patient is over age 50, or if they haven't had a stone in a really long time, these are folks you also might consider doing some imaging in to evaluate for things like, the aorta, masses, or other badness that tends to crop up more frequently in the chronologically gifted segment of the population. Well guys, that's all I got. I hope that this was helpful, and I will see you next time.